Whoops. All right. So today we're going to start off with migraines. Um, the real quick, actually, before we dive in, just because we have different people today, and I just want to make sure this gets talked about early on. If you go in the Gabe Tutoring Google Drive, go to fourth year and then Viro, there is a spreadsheet that has all of the information that you need for virology. So here's all the drugs compared to each other, their activities. Here's the med chem that goes along with them. Here's a chart in how to memorize them. And then eventually, once you get to exam 2, 3, and 4, all the different disease states, how to choose different drugs. So if someone has endocarditis and it's a streptococci, what's the drug of choice, the alternative, the penicillin allergy, and then other sort of treatments, that sort of stuff. I still have to go through and double check everything, but it should be fairly accurate because I had to check my work a lot. So just definitely look at the Viro stuff that's available for you. All right. Without further ado, we are going to start with migraines. Now, I have to start off and say that we don't know what causes migraines. We don't really we don't really have a full understanding of what causes migraines to start, what perpetuates them, what makes them more severe or less severe. They're just kind of one of those things that is a mystery to us in our current level of medicine. One of the big things that we do know is that they are not a seizure. And so that changes how we are approaching them, where we wouldn't necessarily use like anti-seizure medication. We would use specific treatments that are for migraines. So with that in mind, let's take a look at them in full. In the brain, I'm going to bring up a diagram. In the brain, towards the skull, you have certain layers. So you have the skull itself, then you have this subdural space that is filled with different kinds of fluid, and then you have this network space of the subarachnoid, which is kind of keeping the brain connected to the hard skull. When we talk about the migraines, where we think they are playing is in the meninges. And the meninges is this layer between the actual brain tissue and the skull. So it includes the subdural space, the subarachnoid space, and so it's these three layers where we think the migraine is really doing its part. Because of that, what I want you to bear in mind is that a migraine is not an internal brain process, it's around the brain, but it could also happen around the spine as well. So let's look at the different pathologies and then our different approaches. The first kind of thought process that's behind it is the activation of the trigeminal trigeminovascular pathway. Essentially what this is that we believe that the activation of the trigeminal nerves, which are a sensory nerve that originates at the pons part of the brain, the base, and is controlling the the eyes, the jaw, the mandibular branches. So we activate the trigeminal nerve. And what ends up happening is we get the release of vasoactive peptides. One of the vasoactive peptides is substance P. The other one, which plays a more of a major role in migraine pathology, is calcitonin gene-related protein, or CGRP. Once these peptides are released, they they vasodilate, or I'll say that they bind to the CGRP receptor. And then we get a couple of different effects. The first effect that we end up getting is vasodilation in the meninges. Or in other words, we get vasodilation in that space near the skull. And so essentially what you're doing is you're swelling the brain and you're making it push up against the skull, and this is going to cause significant pain. The next thing that can happen is vasodilation near the pons, which again is the location where the trigeminal nerve begins. And this is going to cause incoming signals among the trigeminal nerves to be disrupted. So this would lead to the sensory changes. Primarily looking at the eyes, right? So you get the flashing, you get the, you could have a little bit of vertigo or dizziness. Definitely any kind of light is going to be hyper sensitive. And then the thing that makes migraines so bad and so terrible is we get this release of pro-inflammatory molecules. And this is really where migraines start to spiral out of control. So does anybody know what the quintessential vasodilator is? No matter where it is released in the body, it's just going to cause things to swell. Histamine. Very nice. So histamine is one of our major pro-inflammatory, pro-swelling molecules. Another one is bradykinin. Another is serotonin. And then we have our good old favorite prostaglandins. All of these effects are because of CGRP, right? So what this means is that we have lots and lots of different targets in terms of where we can affect things. We can either affect the downstream swelling, the downstream pro-inflammatory molecules, or we can try to block the CGRP receptor in it of itself. Any questions so far? All right. Like I said, there's lots of other theories about how migraines happen. We think maybe it's the hypothalamic response. Some ideas is like a pain sensitization in the trigeminal system. Maybe like cortical spreading depression. We don't really know. All we can really say is that uh, we know that it involves CGRP, and we know that these pro-inflammatory molecules are available. Um, all right. So let's look at our therapies. There are two ways that we treat uh, migraines. The first is waiting for the migraine to happen, and we do abortive therapy. And for people who have very frequent or very severe migraines, we do preventative treatment. The reason why we don't do preventative treatment for everyone is because the drugs are just expensive. There's also may not be a ton of benefit. So for a lot of stuff, um, we focus on the abortive therapy. What's important to know is that these are for the middle of attack. Right? So our first class of drugs are going to be the triptans. These are all the drugs that end in tryptin. So sumatriptan, almotriptan, zolmitriptan, rizatriptan. I'm sure he's given you a whole list of different ones. But when we look at them, primarily what the mechanism of action is they are serotonin 1B and 1D agonists. And let me put these in capitals. 1B, 1D agonist. What I'm going to tell you now is that this exam, as well as I think antidepressants are in this exam as well, you're going to need to know these different serotonin subreceptors. It is not enough to just know that it's serotonin or serotonin 1. You need to know the difference between 1B and 1D. What ends up happening is that quickly, can someone remind me what kind of GPCR is serotonin receptors? Inhibitory, right? So because of that, and I just want to double check my work. Yeah. The 5-HT1 family of receptors are all GI. So when we look at what their effect is going to be, they are going to decrease the depolarization of the CGRP neuron. What do I mean by that? What I mean is that when we look at the nerve releasing um, when we look at the nerve that releases substance P or releases CGRP, CGRP, these compounds are going to come out and they are going to bind to the CGRP receptor, right? And when they bind to this receptor, this leads to a migraine. Downstream, it will release the histamine, the bradykinin, the serotonin, all those different things. What having this 5-HT 1B or 1D receptor is going to do is when serotonin or a drug binds to this receptor, it's going to try to eliminate that process. So when we look at 1B, specifically, this is going to be found on blood vessels. This is going to vasoconstrict the blood vessels at the base of the skull. And ultimately, what this is going to do is it's going to decrease the sensory changes, right? We talked about how the trigeminal nerve begins in the pons. The pons is at the base of the skull. So if you're activating 1B, you're going to be trying to realign the incoming signals and you're going to try to fix what's going on at the trigeminal nerve. I just need to plug in my headphones. 1D, however, is found on the presynaptic. Oop, that means I drew this in the wrong place. Whoops, my bad. It's found presynaptically. And it's reducing the release of these CGRP activating neurotransmitters. So 1B is focusing on the kind of the sensory changes that go on, whereas 1D is trying to prevent the migraine from continuing. Any questions about this kind of explanation so far? Great. When we look at the adverse effects, though, this is where triptans can be a little bit dangerous. The first is that the what's the best way of saying it? I want to make sure. No. The biggest thing that we worry about with the triptans is their effect on the heart. That's really where we worry about them. They can have a couple of different effects. They can cause vasospasm, coronary artery vasoconstriction. They can cause the in the skin. They can cause paresthesias, which is like tingling, like pins and needles. They also can cause a cold sensation. So your fingers kind of feel like they're freezing. Another thing that we should say for the heart as well is that you get a temporary increase in blood pressure. And then just in terms of general, because we're messing with the vasoconstriction, vasodilation in the brain, of course we're going to get things like dizziness. We're going to be getting things like nausea and vomiting, right? Um, you're going to feel malaise, which is like you just don't feel that great. Whether that's because you are currently in the middle of a migraine or that's because of the drug, I don't really know. But I would say that you know, I wouldn't be surprised if the drug did that. When we look at contraindications to triptans, the biggest thing is their effect on the heart. So heart attacks, coronary artery disease, uh, uh, hypertension, like severe untreated hypertension, peripheral artery disease, stuff where if you have the potential to clot or to occlude the coronary arteries, giving this drug is going to increase your risk of getting a heart attack or a stroke or some sort of issue like that. And we don't want that to happen. So we're going to um, avoid it at all costs. Any questions about the triptans? All right. Older than the triptans, which is what they are based off of, but and we don't really use these anymore, but they are still around for people who maybe can't take a triptan for one reason or another, are the ergots. Ergot is it's a compound that comes from a type of mushroom that grows on wheat. It is the precursor to LSD. This is how we actually discovered it. The two compounds that we talk about are ergotamine and its metabolite dihydroergotamine. And very, very, very similar to the triptans, these guys also are 5-HT 1B 1D agonists. So they're doing the exact same thing that the triptans are doing. This means that you're still going to get the same side effects, right? You're still going to have the vasoconstriction of the coronary arteries, the paresthesias, the dizziness, all these sort of different issues that go on with triptans. The problem is ergots are what are called dirty drugs. They work on other things. One of the big ones is 5-HT2A, which is a GS GPCR. GS? Let me double check. No, my bad. GQ, which makes sense for what we're doing. When we see GQ, we should immediately think muscle contraction, right? Smooth muscle contraction. And one of the big things that happens with 5-HT2A is causing uterine contractions, which leads to one of our major contraindications, pregnancy. One of the complications of pregnancy is developing migraines. And so, some of the most efficient agents for a long time were ergots, but we couldn't give them to pregnant people because of the chance of accidentally aborting their child. Not great. Um, you also get some other dirty drug effects like alpha 2. I think it might be alpha 2 and alpha 1. I can't remember off the top of my head. But you definitely get some uh dirty drugs. They're just not great. One of um the I don't know how much you talked about this. Whenever we talk about ergots or the triptans, one of their major drug interactions is with SSRIs. Now, is it that if you can't use a triptan or an ergot if you're on an SSRI? Not necessarily. You just have to be really careful, right? Um, so the issue is that SSRIs increase the amount of serotonin that is available in the body. And so if you combine these drugs with SSRIs, you have the chance of creating serotonin syndrome, right? So um, you definitely have to double check that someone is not on an SSRI. The other one actually is also macrolide antibiotics. So azithromycin and clarithromycin. And then, of course, you cannot give triptans and ergots together. That you can't combine them. Is this helpful so far, going through this stuff? Okay, great. Other drugs, newer drugs, we have the ditans. Um, the ditans, it's more detail. Okay, I can come back a little bit. Okay. As long as the more detail is like putting things in perspective, that's really what is the goal. Because sometimes more information is helpful. Okay. Yeah, like we should be explaining why. I don't get it. Who knows? He has his way. All right. The ditans, like lasmoditan, which I think is Rayvow, which is I think only the brand name is available. Um, the mechanism is that it is a 5-HT1F agonist. And similar to what's going on with 1B, this 5-HT1F is found in the base of the brain. So again, where the trigeminal nerve is doing its thing, and so it reduces trigeminal nerve neurotransmitter release. So ultimately, what's going on here is that you are decreasing CGRP. Sorry, I said similar to 1B. It should be similar to 1D. Very, very, very similar. one of the important differences between the triptans and the ditans, however, is that 1F is heavily implicated in sedation. For whatever reason, I can't remember it off the top of my head. Oh, methergine. I'll talk about that in a second. 1F just causes this intense sedation. So if you give someone lasmoditan, and they take it, they are going to fall asleep immediately, right? So you need to tell them that this is going to happen. Otherwise, they might say like, "Oh, I got a migraine while trying to drive my car. I'll just take my lasmoditan," and then they fall asleep while driving, and then they get into an accident, and then you're liable because you didn't counsel them. Not great. Real quick, just to talk about methergine. Methergine is kind of a lonely drug. I don't think it's used very much anymore, just because we have other better agents. Methergine is a type of ergot, and specifically what we are using it for is for its 5-HT 2A effect. What this is going to do is it's going to cause vasoconstriction in the vagina and the uterus, and this is going to decrease postpartum bleeding. Like I said, I think we have better drugs now that accomplish this goal. I'd have to check to see if methergine is really used anymore, or if it's kind of like a second line or third line agent, just because we have better, safer drugs. Because again, if you give methergine, even though we're trying to use it for its 5-HT2A effect, you're also getting 5-HT 1B 1D, which might mean coronary effects. So what's the drawback to using methergine is you might cause a heart attack. So yeah, you stop their postpartum bleeding, but now they're at risk of a heart attack. So not great. All right. Now, this begs the question of why don't we use better drugs, right? Why don't we use drugs that are targeting the why don't we use the drugs that are targeting these receptors, the CGRP receptor? And this is where we step into the world of the CGRP antagonists. So this is your uh, rimegepant, which I think is Nurtec. I think the other one is Ubregapant, which I don't remember its brand name. Essentially, what these guys are is they are competing for the CGRP receptor. So what ends up happening here is that the CGRP antagonists that are used as abortive agents, specifically rimegepant and ubregapant, these are competing at the time that the migraine is happening, right? really the and just want to bring up my notes here. Yeah. These drugs work really, really well. I believe they're just really expensive right now. Common side effects that you get are things like dry mouth, dyspepsia, so you get like a little bit of acid reflux, maybe some burping, sedation, nausea, vomiting. Overall, they kind of do the job. Last but not least is our oh yes, constipation. Yes, tons and tons of constipation. Yes, big one. Last but not least, we have our analgesic plus sedative plus vasoconstrictor. So our analgesic could be an NSAID, so ibuprofen, uh, uh, high dose ibuprofen. You might even go into things like ketorolac or indomethacin. Like you're really trying to hit hard with the anti-pain. Could also be aspirin, acetaminophen. Really go back and look at what the contraindications are. Like, can you give an NSAID to someone in kidney failure? Who shouldn't be getting an aspirin? Who shouldn't be getting acetaminophen? Um, don't go too in depth because this is last semester material, but definitely know, NSAIDs a lot of them go through the kidney, acetaminophen goes through the liver, aspirin, salicylate. Also watch out for people who might be on um, uh, blood thinners, right? We don't want to kind of interact with that. Sedative, really what we're going to be doing is butalbital, which is a kind of barbiturate. And we'll talk about barbiturates later, but really what butalbital is doing is just putting the person to sleep so that way they don't have to deal with the migraine. The last thing here is caffeine. And caffeine is acting as a vasoconstrictor to reduce the pressure on the meninges and hopefully kind of reduce that pain that's going from, the brain pushing up against the skull. I've been asked before, well, wouldn't the caffeine kind of prevent the butalbital from doing its job? No, you're falling asleep. Butalbital is going to put you to bed. No amount of caffeine that you have is going to do that. Just know that there are two different brand names, Fioricet and Fiorinal. One is with aspirin, the other is with acetaminophen. Truthfully, I can't remember off the top of my head. I think aspirin is Fioricet, but I don't want to give the wrong info. So that's kind of where that falls in. Any questions about the abortive agents? All right. If we can't, if the migraines are so bad that we can't, oh, actually, real quick, go back to your triptans. I just want to put this in here real quick. For oral therapy, sumatriptan, which could be with or without naproxen, so the Trexamet, and zolmitriptan, and then that there are IV formulations of these as well. I think these are the only ones that have IVPO like crossover. I think the other ones might. I can't remember off the top of my head, but I definitely know that sumatriptan and zolmitriptan, you can go from PO to IV. Why might be a reason that we do IV abortive therapy? Why might someone need a IV therapy? Yeah, super severe, especially if they're vomiting. They're they're not going to be able to take something orally. So we'll do IV therapy. All right. Preventative treatment. What color did I use? Yellow. The first preventative therapy we're going to talk about are also CGRP antagonists. These are not the same CGRP antagonists up above. These are monoclonal antibodies for CGRP or the CGRP receptor. Essentially, the way I like to explain them is that they're like heat-seeking missiles. So you take them on a monthly basis, and they search and destroy CGRP or the CGRP receptor in the brain in order to reduce the number of attacks that someone is going to have. So these are not drugs that you can take while you're in the middle of a migraine. Oh, let me go take my Aimovig or Ajovy, Aimovig, I think Emgality, and Ajovy. These are not drugs that you're taking to cut off the migraine while it's happening. Like their oral counterparts, the biggest thing that's happening with them is constipation. These drugs are taken monthly, which means you have month-long constipation, significant constipation. So it's not a great drug for someone who might be on opiates, right? And already having pretty bad constipation as it is. Other agents, again, these are kind of your last line because they're just so expensive. They get the job done, but they're kind of harder to deal with. Verapamil. Does anybody have an idea of why verapamil is a preventative agent? I believe the reason is because the calcium channel blocker activity of verapamil, this leads to a decrease in CGRP release. I'm not sure if this is the same with other calcium channel blockers. I think it's because verapamil can cross the blood-brain barrier. That's why we talk about it, but I'm not sure off the top of my head. Other The other thing too is that it's going to reduce not vasoconstrict. It's going to no, that's these guys. The non-selective beta blockers. Primarily using these for their vasoconstriction. And really the goal here is we're just trying to reduce some of that pressure that goes on. Really, we're using propranolol or timolol. Metoprolol is used off-label, but I don't think it's necessarily preferred. And then finally, kind of our other option is anticonvulsants, which are actually the first line therapy for preventative treatment, purely because we have lots of evidence for these guys. We know the safety. They're not very, they're not expensive anymore. Topiramate, divalproex. These drugs have a pretty good ability to reduce the severity as well as the duration and then the frequency of the attacks as well. Any questions? All right. All right. Let's dive into sedatives, anxiolytics, hypnotics, and talk about the GABA receptor. All right. I believe the diagram that he gives you, that's kind of a shitty picture. That's a bit better. All right. Did he give you guys this picture to talk about the GABA agents? Like, okay, great. All right. When we talk about the sedative, hypnotic, anxiolytics, what we're talking about here is GABA, specifically the GABA A receptor. And because the GABA A receptor is heavily implicated in reducing CNS activity, which leads to things like sedation, hypnosis, and coma. Couple of things to know. So the role of GABA A is to reduce CNS activity. These drugs are going to pretty significantly turn off the brain's activity, but not all of them are going to be working the same. What's important to know is GABA binds between the alpha 1 the GABA binds. Oh, let me back up. The GABA receptor is a penta penta. I forget how we say it. It's 5 subunits. I'm not going to complicate it. It's 5 subunits made up of alpha, beta, and 1 gamma site. The natural GABA neurotransmitter binds between alpha and beta. What this means is that for a drug to have the complete effects of GABA, it needs to bind in a very similar place to GABA. If you bind in any other configuration than GABA, you're going to have less and less of an effect. What we can say is that depending on which subunit you bind to, you end up getting different effects. So it's always going to be between alpha and beta in terms of the different overall effects that we talk about. But really what it comes down to is that if you're alpha 1 to beta 2, then we are talking about significant sedation. This is where we see dependence and the anticonvulsant effect. If, however, your drug is more apt to bind between the alpha 2 receptor, the alpha 2 subunit, and beta 2, so in your specific receptor, instead of it saying alpha 1, it says alpha 2, then you're going to be getting, instead of sedation, more anxiolysis, antidepressant. So again, you're still depressing the brain activity, but you're getting less and less and less. If you bind at the alpha 3 receptor, then you have what's called sensory motor gating, which means that there's a slight shifting in how the brain is able to handle movements and sensory information. And then as well, we have anti-hyperalgesia, which means that it's decreasing hypersensitivity to pain. Alpha 5, again, sensory motor gating, but this time we have cognitive impairment. So your brain's ability to think is much worse. Now, not every drug binds to just one receptor. Some drugs are going to bind between, they'll do alpha 1, alpha 2, and alpha 5. Some are doing 2, 3, and 5. Some are just doing 1 and 3. It changes depending. And it changes within a class as well. Some benzodiazepines are better binding at certain ones. Some are better binding at other ones. But really, the big thing to bear in mind is that in general, you're getting all of these effects. The biggest thing is that the worse the side effect, the higher the dose. That's really what it is. Some drugs are, because of the nature of how they are just not able to get to those worse side effects. I'm talking specifically about the benzodiazepines. Others can. We'll kind of talk about that more specifically. Let's talk about do I want to talk about let's do the barbiturates first. I think that's a good place to start. All right. Barbiturates. Barbiturates are really, really old drugs. They're the drug that what was her name? The blonde girl in the white dress. Marilyn Monroe. It's the drug that Marilyn Monroe overdosed on, slash was executed by the CIA, depending on what you believe. But in general, what the barbiturates do is that they are positive allosteric modulators of GABA A. Are they? Yes. So what does this mean? What the GABA A receptor does normally is it acts as a chloride channel. So when GABA binds to the receptor, this leads to an influx of chloride into the cell. I'm going to say it like this. Opens the receptor, which is a chloride channel, leading to an influx of chloride. And this is going to cause hyperpolarization of the cell. If a cell is hyperpolarized, meaning that it becomes more negative, then we get decreased neuronal activity. So whatever neuron that GABA receptor is is attached to, now it's going to do its job worse. A lot of times this is things like it could be glutamate, it could be serotonin, it could be dopamine, it could be a lot of different things. But essentially what it is that GABA receptors are turning down the activity of the brain by making everything super, super negative, right? What the barbiturates are doing is that they are the barbiturates bind to the allosteric site. So they're not binding at the same place that GABA is, they're binding somewhere else. And this increases the GABA binding to the receptor. So in other words, barbiturates make GABA fit into its binding site much, much better. And we can see that. So on our diagram, here are the barbiturates, and here is GABA. And where do we notice that barbiturates are binding? Very similar places, in between alpha and beta. And this is going to essentially make GABA sit in this little spot much, much, much better. What this means is that you end up getting way more chloride coming in, which is going to cause way more influx, which means that we're going to hyperpolarize the cell even more, and means that we're going to decrease the neuronal activity a ton. So just to summarize what these effects are. So the three effects that you must remember about barbiturates. The first is that they augment the function of GABA. And by that, we mean that they increase the fit, right? So GABA binds to the receptor better. Not only do they help GABA bind to the receptor, but they increase the pore size of the channel itself. This means that there's more chloride coming in per second, right? So GABA normally can get 1 chloride to go through per second. Having a barbiturate means that 2 can go in. So you're hyperpolarizing at a much, much greater rate. What this amounts to is that at high doses of barbiturates, you are increasing the maximal effect of GABA. GABA on its own can only let 1 chloride through. Barbiturates force open the pore so that way more can get through than normal. This is why I'm sure he showed you like the chart and that explains like sedation, hypnosis, and anesthesia, that sort of thing, and then coma and death. This is why barbiturates can go higher, because they can actually force the pore to open wider. And then the last big effect of them is that they antagonize excitatory neurons. So like I was saying, these decrease the effect of glutamate, NMDA, all those sorts of stuff. So even though the brain might want to ramp up the excitatory side of itself, barbiturates are preventing that. Any questions so far? All right. One of the parts that I remember hating about this section is the half-life or the duration of action of the different drugs. You do need to know what the duration of action of the different drugs are. You have to know them. First are the ultra short acting, which means that they're working for about 15 minutes to 3 hours-ish. And this includes thiopental and methohexital. Then you have your short acting, which are working for 3 to 6 hours. Your pentobarb your secobarb. Then your intermediate acting, which is 6 to 12. Amobarbitol, butalbital. And then finally, your long-acting barbiturates, which are 12 to 24 hours, which is your phenobarbital. And also primidone. That's the other one. It's important to understand where the utility of the barbiturates come in, because depending on their duration of action, you're going to get lots and lots and lots of different effects, as well as what sort of dose you're going for. So in terms of the duration of action, we have them here. When we talk about dose, our low dose is primarily going to be as a sedative. So we're trying to put the person to sleep. Their medium dose is a hypnotic. So we're preventing them from no. Hypnosis is unarousable, I think is the way that it gets put. I'd have to double check. Sedation is that you're tired. Anxio likes this. Hypnosis is I think just staying asleep. I don't know why that slipped my head. And then finally, high dose is your anesthesia. The big thing to remember with anesthesia is that we get amnesia at these doses. So we're preventing the body from remembering whatever trauma we're doing to it while it is, asleep. So, for instance, if we're going to slice it open because we're doing a surgery. So with these in mind, we can get a different ideas of how we are going to use the barbiturates in different ways, based on their duration of action and their dose. So, for example, if we look at let's look at the ultra short acting. What would be some uses of the ultra short acting? Why would we want a drug that only lasts maybe 15 minutes? Pre-op? Yeah, right? So we want to quickly knock someone out. So maybe we're doing a high dose pre-op, right? So we're knocking them out. They fall asleep and they're not going to cause an issue. What could possibly be? Oh, I didn't say this specifically. Mostly because it's not. I don't know if it goes under high dose. I'm going to put it under other because I think it depends on the drug. Anticonvulsant is the other one that I want to put down. So one of the uses is in situations like status epilepticus, right? Where someone is having a seizure that is not ending on its own. So someone could have epilepsy and maybe they're having a seizure for about a minute and then it stops on its own. Status epilepticus is when the seizure is not stopping. And so we need a drug that we can slam into the person to prevent the seizure from continuing. And maybe we're going to use methotrexate or thiopental because we need to get the drug in them, but we need to stop the drug to see if the seizure will stop on its own, right? If we hit them with a long-acting drug like phenobarb, oh, great, we put phenobarbital in them, and then in the middle of the night, now all of a sudden they're having a seizure again because we didn't check to make sure that we solved the issue. I'll just put this in here because it's relevant to my job, but sedation for electroconvulsive therapy. And when we get to antidepressants, someone remind me, we'll talk about that a little bit more. Oh, my bad. Oh, we'll fix this in just a second. For short acting to intermediate, this is my bad. We don't use ultra short for pre-op. General anesthesia. I'll explain this in a second. We use short intermediate acting for pre-anesthetic sedation. The reason why we use short-acting drugs, one that maybe lasts about 3 hours, is because maybe it's going to take a while for someone to actually get into the OR, right? Maybe it's going to take longer than the 15 minutes. So what we do is we give them their pentobarbital because it's going to calm them down. They're going to get really sleepy, and so it gives us time to kind of wait for when they're going to go into surgery. The why then during surgery are we going to use a short-acting drug? Why wouldn't we want to use a longer-acting drug for the duration of the surgery? Reason is because we want them to wake up quickly, right? Once the surgery is done, we don't want the person to stay sedated. So if we use a drug that only lasts about 15 minutes, we're constantly infusing them with IV fluids, with thiopental in it, and then as soon as it's done, we cut it off, and they're going to wake up within 15 minutes. Other thing you're going to see short intermediate acting is for anxiety, right? Someone's having a panic attack, you can give them these kind of short intermediate acting. And then for long, primarily we're going to see things like anti-seizure, alcohol withdrawal, and primidone is tremor, but that's really it. That's really the only two. He explained ultra short is pre-anesthetic. Okay. All right. I follow what he says then. At least when I went through my rotation that we talked all about anesthetics, which is where I'm pulling this information from, we had group short. But if he puts pre-anesthetic under ultra short, follow what he says. Okay. All right. Great. All right. We're gonna wrap up here because I don't want to go into benzos because that is a big discussion. We also have to talk about adverse effects. Remind me that the next time that we meet, we have to do adverse effects, and then we'll go into benzos. All right, great. Of adverse effects of barbiturates. Great. I think the next time we are meeting is on Saturday. Just double check the classroom, and I will see you all this weekend. Have a good weekend. Have a good Friday. Get fucked. Can I put that in the recording? Yes. Yesterday's video is up. I'm the tutor. I can say whatever the fuck I want. If I want to swear, I'll swear.